Okay, good morning. Okay, good morning. This video is about irrational fears of gastric cancer and how that impacts the choice of the best weight loss surgery. I'll just do a couple things real quick to introduce it. You may not want to watch the entire video, but in short term, general surgeons who are experts and understand the potential risks of gastric cancer and the Billroth 2, that's the loop gastro connection that we use in the mini gastric bypass. General surgeons who are experts, oncologic cancer surgeons, trauma surgeons who understand the basics of general surgery, the background of general surgery, the history of general surgery, they use the Billroth 2 type connection every day. In other words, they have no hesitation, they publish about it, they use it, they don't defend it at all because it's unnecessary to defend it. Yet many bariatric surgeons, and I would argue because of their limited general surgery knowledge and expertise, fear the Billroth 2 and the loop that we use for the MGB. And so this talk is about that kind of dichotomy, and I come down on the side of the general surgeons who are knowledgeable experts in the field. The other thing is there are studies that show that there's a risk of gastric cancer after the Billroth 2. And so if you heard that, it's pretty scary. I mean, cancer, I don't want cancer. But what we want to point out is that there is an understanding that's often missed by the people who raise these concerns, because there's also a risk of getting cancer after a CAT scan. The studies are very clear now. If you have a CAT scan, you're more likely to have cancer. You know you're more likely to get cancer if you eat a hot dog. And there are studies that show there's an increased risk of getting brain cancer after using a cell phone. Now, people still, as far as I'm aware, use cell phones, eat hot dogs, and get CAT scans. And you don't hear the people who raise concerns about the MGB running around saying, beware of hot dogs, CAT scans, and cell phones. Yet, the increased risk in the few studies that show that there's a risk of gastric cancer after Billroth 2 show that the risk is less than having a CAT scan or eating a hot dog. So, again, I liken it to say, if I told you that I'm going to give you $1 million, but I'm going to double the chance that throughout your life, 2 times greater chance you might be struck by lightning, I might take that. And if you're frightened, for example, to ever leave your house because you might be struck by lightning, I don't know if that's a good rational decision. So we're going to talk a little bit about those kind of judgments. And it turns out lots of people, when they hear the word cancer, are tremendously frightened and lose the kind of rational decision making that they ought to use. So for example, I would argue, even though it's very clear if you leave your house, you could be struck by lightning, I still recommend that when you feel like it, you leave your house. And we're going to talk about the fact that experts who really know about this area have no concerns about the Billroth 2 and routinely use the Billroth 2. And it's people who have less knowledge, less expertise, who have raised some concerns. So we're going to talk about that in this tape. Give you a little bit about my background. I was at the undergraduate medical school, and it's interesting, my teacher was a very famous physiologist and then surgeon named Dr. Lester Dragstad. And he was interesting because he was a pioneer in the invention of an operation. And at the time when he brought it forward, it was intensely controversial. People were bitterly critical of him, and they yelled at him. He invented something called the vagotomy and pyloroplasty, and he was right and his critics were wrong. Interesting. I spent 2 years at the Heart, Lung, and Blood Institute in the NIH in Bethesda. For 20 years, I was at the University of North Carolina. I was an associate assistant and full professor. I was the chief of the section on medical informatics in the section on trauma and critical care. I was the author and director for 10 years of the North Carolina Trauma Registry, and we published a lot of papers and since I left, I'm not sure there have been any more papers published, although I'll have to check. I was the first author of the American College of Surgeons Trauma Registry. Now, I've written over 100 papers, and my most recent 2 are studying the mini gastric bypass here in India. And maybe we'll do another video on those 2 because the findings are really exciting. Basically, Dr. Kular is a great surgeon. My specialties included trauma, critical care, medical informatics, and bariatric surgery. And it's interesting, when I was going to be hired as a new attending at the University of North Carolina, my boss said, we need you to participate in the trauma, critical care, things like that. You're going to do computers for us, and we also want you to participate in bariatric surgery. And I said, hey, well, I'm really excited about the job offer. I don't want to do bariatric surgery. And so he countered that with, do you want the job? And so I said, well, when you put it that way, sir, I've always been interested in bariatric surgery. And I'm old enough to have done a lot of open general surgery for ulcers. This is important because peptic ulcer surgery often included either truncal vagotomy and pyloroplasty, and also truncal vagotomy, antrectomy, and Billroth too. So I did lots of antrectomy and Billroth too. Now that's rarely done. I think it's one of the reasons why some of the younger bariatric surgeons, as well as some of the older bariatric surgeons, have forgotten this chapter in general surgery, is because they haven't done a lot of these cases. They're not familiar with the physiology and the history. So I've been doing bariatric surgery for over 30 years. I used to do the old open Roux-en-Y and gastric bypass, and the vertical banded gastroplasty. And the first MGB was done in 1997, and it followed basically a trauma patient who had the bottom of his stomach taken out because of a gunshot wound, and I repaired it by using a Billroth 2, and we used that same standard, usual general surgical technique to do a gastric bypass. Did 60 cases at the University of North Carolina, all of which did well, so we moved on to offer the MGB now some 15 years later, over 6,000 patients and all around the world. Now, we've got some people watching this video who say might be a surgeon and might be interested in starting the MGB, and we argue, and sometimes people criticize me because I emphasize how easy the operation is. It's a natural surgery. There's not some of the difficult steps in the other forms of surgery that can get you in trouble. So, for example, the dissection, where you're near the esophagus and the top of the stomach, is potentially dangerous. And if you look at the reports from people who do sleeve operations, you can see 1, 2, 3, 4, 5% leaks or greater. And you can see some of these patients staying in the hospital up to 3 to 6 to 9 months. And so MGB, we recommend don't do that. Don't go in that area where that leak is. And that, we think, decreases the risk of leaks compared to, for example, a sleeve. The Roux-en-Y is relatively complex, and there are studies showing up to 16% incidence of bowel obstruction, and the studies from around the world seem to show a much lower, maybe even an absent risk of bowel obstruction, although there's probably some, such that MGB might be safer than Roux-en-Y. Anyways, we argue MGB is good, but it's not perfect, and there are some tricks and traps that we recommend that surgeons, if you're interested in considering this, really take advantage of local experts, and of course you're always encouraged to contact me at any time if I can help. I'm not going to spend a lot of time on the results of the MGB, but let's summarize the results. What we've got almost 15 years out. We had a lot of skeptics when we first brought forward the MGB. The critics said, oh, they won't lose weight, and they were wrong. They said you need to have a small pouch. They were wrong. They said you had to have a small connection, the anastomosis between the stomach and the bowel. They were wrong. And so now we've got almost 100 papers from all around the world. And what we can tell you is, from all these papers, we can tell you this. By every measure, in every study, from every author, the MGB is equal to or better than any other type of weight loss surgery. Now, if I just said that, I think people should be naturally skeptical. But let me say it again. By every single measure, in every study, by every author, the mini gastric bypass has been found to be better than any other form of weight loss surgery. So, it's good. Now, on the other hand, there have been a list of kind of skeptics, and they've raised different concerns, and one of the concerns is, yikes, even though it's such a good operation, maybe there's going to be cancer. And so that's what this tape is about. But I want to emphasize that we should also be judging the critics as well. In a nice way, we want to say that if someone raises concerns and they're actually wrong, that is, they don't know the basics of general surgery, they don't know the history of general surgery, they don't know the physiology of the human being and animals, you want to be concerned about them. So if somebody just says, oh my goodness, cancer after Bill Roth 2, and we're going to show that raising that concern is really misunderstanding of really some basic general surgery, that it kind of reflects badly on them. And what I mean by that, they've done studies looking at surgeons and their knowledge base. So one example that I like is from Canada, and they looked at colon surgeons, and they happened to have all these colon surgeons' outcomes. How many people died, complications, leaks, infections, cancer coming back, recurrence, things like that. And they gave each one of these surgeons a test, a knowledge test. How much do you know about colon cancer surgery? You're a colon cancer surgeon. What do you know about the truth that we know right at this moment about colon cancer? And they found that the less the colon cancer surgeon knew, the worse their patients did. So we'd like to argue that it's incumbent upon physicians, if they want to be critics, I think it's wise to be knowledgeable about their subject. So we often see people who have looked at the medical literature very briefly, and they found this association that's been reported in some studies. There are studies that say there's an association between a Bill Roth 2 loop gastric jejunostomy and gastric cancer, and so they talk about it. And what we would argue is you could do the same thing about cell phones. You could say, I found an article that says cell phones cause damage to the brain's neurons. And so go around and say, maybe Verizon is really a dangerous company. And I don't know, Verizon might be a dangerous company, but I'm not sure it's because cell phones cause damage to the neurons. As I said, there are studies showing that hot dogs can cause stomach cancer. The more hot dogs, the more processed meats you eat, the more stomach cancer people develop. And again, you could make some conclusions from that, but I think it's important to have a deeper understanding than just going to the local grocery store and say, warning, stop, don't eat a hot dog. So what we're going to try and do in these next few minutes is give you more detail to understand this more clearly, and we're going to raise concerns if somebody just pops off without a lot of background knowledge and says, ooh, there's a risk of gastric cancer after Bill Roth 2. Yes, there are a couple papers like that, but again, there are a lot of different papers. And so let's look at the details in this presentation. I'm going to go through a couple things, and I'm going to just tick them off so you can see where we're going here for the rest of the video. I did a video on this yesterday, and it took a long time, and I'm going to try and be a little bit more succinct. I don't know if you know this, but sometimes I talk a lot. So, number one, we're going to talk about gastric cancer. If you don't know about gastric cancer, when it occurs, how often it occurs, how many people die from it, what's happening with it, I think it's going to be hard to make a good conclusion. For example, if you don't know anything about lightning, and I say there's a possibility if you stand outdoors you could be struck by lightning, maybe you say, oh my goodness, I'm never going outdoors. And my bias is that's a misunderstanding of the data. So, what about the fact that gastric cancer is declining in risk? Again, we're going to talk a little bit about esophageal cancer, which can be associated with acid burning of the lower esophagus, and the fact that the sleeve and the band can markedly increase acid burning of the lower esophagus, and thus have this high probability that long term you're going to see, with all this acid burning of the lower esophagus and maybe up to a third of patients, you might see some esophageal cancer. And esophageal cancer is growing, one of the most rapidly growing cancers in the United States. On the other hand, in a kind of wonderful outcome, gastric cancer risk is plummeting. It's decreasing tremendously, over 50% over the past several decades. And we're going to talk about the fact that it's the refrigerator that's largely affected that. I'm going to talk about the causes of gastric cancer. If you understand the causes, there's some tricks in the data that help you understand why a lot of surgeons who are knowledgeable about gastric cancer and Billroth-2 are not very frightened about Billroth-2 being associated with gastric cancer in a few studies. So we'll come back to that. But basically, the causes include eating bad diet, smoking cigarettes, and processed meats that have nitrates and nitrites in them. The nitrates and nitrites act as direct carcinogens. They cause cancer. So processed meats, beef jerkies, dried, smoked meats, and processed meats like hot dogs can increase the risk of gastric cancer. And conversely, a healthy diet that includes a lot of vitamin C containing foods, citrus, fresh fruits and vegetables seems to decrease the risk of gastric cancer. And the impact of those factors is much greater than any study showing an impact from a Billroth-2, and we'll talk a little bit about that. Probably most importantly is most of the studies showing an association were done after we were done before we figured out that the bacteria, Helicobacter pylori or H. pylori, is a primary cause of gastric cancer. So we now have pretty good data. One of the first infectious causes of cancer in humans is gastric cancer. And the bug, the bacteria that causes it, is H. pylori. So again, let's imagine that you had this fear that you're going to get gastric cancer. I mean, well, you could treat the cause, which is H. pylori. So again, simple things, and you need to understand it. We're going to look at the data that's published on Billroth-2 and gastric cancer, and then we're going to emphasize what I started with, which is general surgeons routinely use the Billroth-2. And we'll look at some of the areas of the highest frequency of gastric cancer in the world, and that oncologic specialists routinely use the Billroth-2, and in their papers, they don't make a peep about using the Billroth-2. They don't come out and say, well, it's important for us to justify its use, because they don't have to justify the use, because oncologic surgeons don't argue with one another about it, like the bariatric surgeons who are not very knowledgeable. So we'll talk about that. Then we're going to talk about that there are a lot of good studies that show there's no association with people who've had Billroth-2 and gastric cancer. And so the idea of a study like this is you can say, let's take a whole bunch of people who smoke cigarettes and see if they get lung cancer. And they're going to get lung cancer, let's say 1 out of 1,000. And then we'll look at the general population, and maybe they only get it 1 out of 10,000 or 1 out of 100,000. Then we can say, gee, look at lung cancer after smoking, it's 10 times or it's 100 times more common. So this is a big deal. All right, well, there's a lot of excellent studies, and the one I like from the Mayo Clinic showed that after following people who had a Billroth-2 for 5,000 patient years, I mean, the whole group added up their years together and follow-up was 5,000 patient years, 2 people out of the entire group in the long-term follow-up had a gastric cancer. And in the general population, they guessed that they should have had about 3. So what this study showed from the Mayo Clinic surrounding county called Olmsted County in Minnesota was that if you had a Billroth-2, you're less likely to get gastric cancer than the general population. So we want to point out that there are studies that suggest there's no association. Now there are some studies that do show an association, but there's a trick to that which I think most of the critics don't quite read and understand, and that goes like this. So you find a bunch of people who had Billroth-2, and they have a slightly increased risk of gastric cancer, usually taking 20 to 30 years after their surgery. Okay, all right, so maybe there's a risk. But there's another trick. You have to how did you become a member of the group of people who had Billroth-2s? I mean, they just didn't go out and randomly choose people off the street. They had something else. What? They had ulcers. In other words, this is the old days before Prilosec and cimetidine and drugs like that, Tagamet. We used to do lots of these operations. We would do Billroth-2s as part of the operations for ulcers. And so if we look at these studies that show an increased risk, the people who have Billroth-2s not only had Billroth-2s, but they had ulcers. And why do we say that? Why is that important? because H. pylori, the cause of gastric cancer, is also associated with ulcers. That's how the two Australian doctors got the Nobel Prize. They showed this infection causes a lot of ulcers. So if you picked up a whole bunch of people who had Bill-Raw 2s, you're probably picking up a whole bunch of people who have infection with H. pylori, and that's back before we knew how to test for that or even knew the bug was there. So if you find a whole bunch of people who had Bill-Raw 2s happen to get a slight increased risk of gastric cancer later on, as my son says, duh. I mean, you have to wonder about the critics of the MGB. I mean, I wonder if they read any of the scientific literature. So just let me say it again, okay? Imagine the plague comes through in the Middle Ages. And if a plague catches a house, they put a red flag on the house because it's dangerous, because the plague spreads by contagion. So the critic of the MGB could say, looks like the red flag is causing the plague. They're not really saying that, but they probably just haven't read this data. But let's say it again, because this is really important. There are a lot of studies showing there's no association between Bill-Raw 2 and gastric cancer. There are some that show a slight increased risk of gastric cancer 20 years after Bill-Raw 2, but people who had Bill-Raw 2 probably had ulcers. They probably had H. pylori, and that causes gastric cancer. The red flag is not causing the plague. I don't know. It should be. We should probably take this more seriously. But there are people who they're scared of the Bill-Raw 2, and they say it causes cancer. So, anyways, you see my point? All right. Anyways, let's do something else. All right. So some of the surgeons who say, "Oh, I'm frightened of MGBs might cause cancer." Well, let's suppose that they are honest. They are concerned about the welfare of people in society. You know. These are not their patients, but they just, they're good-hearted people. They're raising a concern. Well, but I have information for these surgeons. They may not know this. There are hundreds of thousands of people that are about 20 or 30 years after having had a Bill-Raw 2. They're all over the world. I did lots of them. Okay? They're all over the world. People who've had a Bill-Raw 2 for their ulcer disease. Okay? And they're getting to the time period where they could be getting gastric cancer. What do you think should be done? If these surgeons kind of follow their own logic, they don't need to really worry about the few MGBs I'm doing. They have a whole giant population of people whose lives they could save by going out and raising the alarm. In America we have the story of Paul Revere. He ran through the streets and alerted the colonists that the British were coming. So if you're a critic of the MGB and you're worried about the Bill-Raw 2, and this is an honest concern, I have news for you. You have bigger fish to fry. Why don't you go out and start making a national policy in your country, in your county, in your city? Look for all these Bill-Raw 2 patients who are 20 or 30 years out and get them diagnosed with endoscopy and look for the gastric cancer that's coming. Warn them. Put up newspapers and say, warning. Put up, TV spots, put them on the internet and say, look out, look out, look out, gastric cancer is coming after Bill-Raw 2, look out. But why are we not doing that? It's been studied. Why are we not doing that? Why is that silly? We studied that. Numerous people have studied it. They've endoscoped thousands of people who've had Bill-Raw 2s. They've actually found a few gastric cancers, and the rate is about equal to the general population. So there's no increase in risk. It doesn't make any sense. Gastroenterologists are not busy looking for Bill-Raw 2 people. You don't send out warnings to those people. I mean, you could tell them to beware because maybe they've got an infection with Bill-Raw 2, but just there's not much being done on that. And so what you've got is somebody who really lacks that knowledge of this really basic general surgery data about gastric cancer, and they're raising concerns about the Bill-Raw 2. So, I don't know, we'll talk about that. Okay, now human decision making, you can't be too critical of surgeons who raise this concern because there are numerous studies now that show that human decision making is not as good as we would like. We'd like to think we're very cool and logical, and physicians make clear, unbiased decisions based on the data, but as I think I would argue, this is a good example where sometimes, rationality is maybe not as good as we would like, and there's a lot of research on that. I'm not going to spend a lot of time on it. I will tell you that in preparation for the second International Consensus Conference that we held in Paris on the mini gastric bypass, I did a survey of about 100 bariatric surgeons, and they had about experience about 39,000 cases. And there were a lot of MGB advocates, but there were also a lot of MGB skeptics. And when we analyzed the data, one really interesting thing came up apropos that colon cancer surgeon study. What we found is when we asked the surgeons questions on the survey, the more frightened that surgeons were of gastric cancer after Bill 2, the less knowledgeable they were. In other words, we asked about how often gastric cancer happens, and I have all the data on this, but let me say that again. We asked them, are you frightened about having gastric cancer? And after Bill 2, those people who said they were frightened about it answered questions about general surgery, gastrojejunostomy, gastric cancer, much less accurately than those people who were not worried about gastric cancer after Bill 2. That is, people were frightened, the less knowledgeable they were. So we'd like to say, how about if we have some education? That's what we're going to do now. Okay, gastric cancer is declining. I won't spend a long time on it, but it's decreasing precipitously all around the world. There's been a long-term decline. They expect rates to decrease from 84 to 41 cases in Osaka, Japan, 41 to 18 in females during the same period. Public health gastric cancer rates from Harvard reported 60% decline, that most of these are from H. pylori and smoking, and that by 2040 there'll be another 47% decrease. Most of them again are from smoking and H. pylori, so if you're frightened about gastric cancer, hello, there's something to be done. And the data associating Bill 2 with gastric cancer is not present, so I wouldn't worry about that. So there's worldwide a massive decline in gastric cancer because of decreased smoking, because of refrigeration, which decreases nitrates in preserved foods. There's more fresh fruits and vegetables, and there's a decline in H. pylori, and it's got nothing to do with Bill 2. Okay, H. pylori can cause peptic ulcers and cause stomach cancer. It's important to know that. Again, if this is not upper mind when you hear this, comment about gastric cancer and Bill 2, you could be confused. Smoking's very important, diet's very important, diet high in fresh fruit and vegetables makes a big difference. Plus, obese people are more likely to get gastric cancer, and so MGB, if you want to prevent it, treat the H. pylori, stop smoking, don't eat smoked, salted, or pickled foods, do eat fresh fruits and vegetables, and maybe try and treat the obesity and be more active. If you fear gastric cancer, treat H. pylori. Treat H. pylori. I don't think you need to worry about a Bill 2. What we would argue, again, is surgeons who fear gastric cancer associated with AMGB are not really clear on the research information on this topic. So, many studies show, they've looked at studies, and there's no association. And this is that Mayo Clinic study. They had 338 patients followed for 25 years, of over 5,600 person years. They found 2 cancers after following up these people for a total of 5,000 patient years. This is published in the New England Journal in 1983. The predicted rate of cancer from the general population was 2.5, in other words, almost 3. The ones who had Bill 2 was 2. So it's good. You should have a Bill 2 to decrease your risk. But remember, this was published in 1983, and the risk of cancer has declined by more than 50%. So if we were to do that study today, the number of cancers after 5,000 patient years is less than 1. You might need 10,000 patient years to find one gastric cancer. In other words, how many patient years would you have to follow people to find somebody hit by lightning? 10,000 patient years? Maybe. In other words, we're talking about a low frequency. A low frequency. It happens rarely. Okay? So the future risk of a Bill Roth 2 done today, given that gastric cancer is precipitously declining, is dropping, and now we know how to prevent it. We could treat H. pylori. And we're talking about maybe less than 1 per 10,000 patient years of follow-up. In other words, what if you said, if you have MGB, the chance of being hit by lightning goes up by 2. Instead of 1 per 10,000 years, you have 2. I don't know that I would not have an MGB when the risk of bowel obstruction and death after Roux-en-Y is 16%. I mean, we're just not being able to parse rationally this risk. And that's understandable. Humans are not really good at that, but that's what this talk is about. All right, so lifetime risk of 5,000 patient years follow-up of getting a gastric cancer then in this study is about 0.2%. And it's going down because the risk is going down. All right. Now, again, some studies do show an association, but remember the Bill Roth 2s were done for ulcers, and ulcers are caused by Nobel Prize winning Australian doctors show H. pylori. Ulcers are associated with an increased risk of gastric cancer. Why? Because H. pylori infection. And it's interesting, the relative risk, do you know what the relative risk of getting cancer after having an ulcer? Turns out it's remarkable. It's like the studies that show Bill Roth 2s associated with gastric cancer. They're the same. Okay. Excuse me. So, there are, in one series, they looked at 12 studies, and they found that 7 showed a small increase in risk, but remember, those patients who had Bill Roth 2 had ulcers. Okay, again, bariatric surgeons, in some cases, fear the Bill Roth 2, but general surgeons choose it routinely, trauma surgeons choose it routinely, and oncologic surgeons choose it routinely. In 2009, there were 16,000 Bill Roth 2s done in the United States. A recent study from Eastern Carolina University showed that Bill Roth 2 was chosen about half the time and Roux-en-Y half the time, so it's equal. And none of these studies, when they report them, do they go into defending the choice of Bill Roth 2. It's only the bariatric surgeons who are being critical of the Bill Roth 2 in the MGB, nowhere else. So what we want to argue is that bariatric surgeons are the ones who fear the Bill Roth 2, general surgeons use it routinely. And in particular, we want to say that there are areas in the world where gastric cancer is particularly high risk. 2 of those areas are Korea and China, and those surgeons who operate on cancer patients in those areas are very attuned to the risk of gastric cancer in their patients, and the studies show clearly they routinely use the Bill Roth 2. You think they would be choosing the Bill Roth 2 for their gastric cancer patients if their surgery caused gastric cancer? Yeah, probably not. All right. There's some studies from Europe. They did big-time studies. And what they found is if you ate more than 50 grams a day of processed meat, you had an increased risk of gastric cancer because of the nitrates and things. Now, it turns out 50 grams is around the size of a hot dog. So, it turns out the risk is about 5 times greater to eat a hot dog every day than it is to have a Bill Roth 2 in even the worst studies. And remember, there are a lot of studies showing no increase. But if you pick out the worst studies and say, yikes, this shows an association between gastric cancer and Bill Roth 2, it's much more deadly to eat a hot dog. So again, let's suppose you take the physician who's being critical of the MGB because of gastric cancer. You say, you know, this is a good, honorable person. He wants to protect people from gastric cancer. He has a much better likelihood of protecting people from gastric cancer if he generates a campaign against hot dogs. because they're a lot more likely to cause gastric cancer. And also, I don't see many people wound up over eating hot dogs. I mean, I'm not sure they're very good, and processed meats I don't think are a very good choice, but the number of gastric cancers coming from hot dogs is low, and even in the worst studies, Bilirubin 2 is like 2 times less than a hot dog as far as the risk. And there are a lot of studies showing no risk, and the ones that do show risk are because they probably had the Bilirubin 2 for H. pylori, and it's not the Bilirubin 2. But let's suppose you assume that these are good-hearted physicians. They're trying to do the right thing. They want to help people save lives. They should, they should stop people from eating hot dogs. There's the same kind of data for CAT scans, and I'm going to skip it. So, I'm going to summarize and finish up here. I'm having too much of fun. So one, you should know gastric cancer is declining more than 50% recently, and they expect another 50% decline, and the primary cause is either smoking or H. pylori. So if you're worried about gastric cancer, you don't need to worry about Bilirubin 2, stop smoking. And if you want, you can treat the H. pylori. The environmental causes are clear, as I say, smoking, processed meats, and a diet that's low in fresh fruits and vegetables. And so again, it's easy to fix these things. There are some studies that show that there's an association between Bilirubin 2 and gastric cancer, but these studies are in patients who've had previous ulcer disease, because that's why they had their Bilirubin 2, and ulcer disease is often caused by H. pylori, and that causes gastric cancer. So if you were to study these people who had Bilirubin 2, who you know are probably infected with H. pylori, would you be surprised that the house that has a red flag on it has plague? It doesn't mean the red flag is causing the plague. And there are many large-scale studies showing no increase risk. And so, finally, if it was a big deal, why don't we endoscope all these other people? You don't worry about the MGBs. There are not that many MGBs in the world being done. There are hundreds of thousands of people getting the Bilirubin 2, and some of them are 20 or 30 years out, the timing that it takes to develop cancer in these studies. So if you want to get excited, let's do a big international campaign in favor of endoscoping and finding cancer in Bilirubin 2 patients, and nobody's doing this. There's no general surgeon or gastroenterologist thumping the drum to look for gastric cancer in Bilirubin 2 patients, because they've done the studies and it's pretty rare. So, in 2009, 16,000 Bilirubin 2 procedures, and nobody's worried about these surgeries or surgeons. It's just bariatric surgeons with limited experience who are bringing up this issue. So the Bilirubin 2 is very safe and effective. It's used in the MGB. It's a standard procedure, and those people who raise concerns about it, you know, we want to be nice to them and respectful, but they might want to look more detail at these particular topics. And if you're a patient, certainly get the advice of your physician before you make a decision, but I'm just giving you my opinion. If you're frightened of gastric cancer, which is a reasonable fear, there's things you can do. I personally wouldn't drink much alcohol. I'd avoid tobacco and smoking, of course. I wouldn't have processed and preserved meats very often. I'd treat H. pylori if I had it. I'd eat fruits, fresh fruits and vegetables, and maybe even yogurt and green tea might help. But a Bilirubin 2 makes no difference. Let me finish up. We know that these surgeons who raise these concerns are good, honorable people, but a Bilirubin 2 makes no difference. A Bilirubin 2 makes no difference. A Bilirubin 2 makes no difference. I wonder if you know what my opinion is. A Bilirubin 2 makes no difference, and my bias is, in a very gentle way, if we see somebody who raises this concern in a nice way, we might want to say, maybe you'll want to look into this topic a little bit more. And probably they don't want to see this tape. It's probably not as gentle as I should have been. I hope you'll find it in your heart to forgive me, but it just, I don't know. I wish them the very best, but it's not the Bilirubin 2. Thanks very much. Stay tuned. We'll be doing some more videos again soon.